As you know, this is the second class on the topic of clinical evaluation of a case with ptosis. So this is our time frame. In the previous class, we highlighted some basic points, an overview about some points regarding ptosis under the heading of opening slides, all right? This one. And today, we are going to start talking about the checklist, the points to be assessed whenever we have a case of ptosis in the exam or in our clinical practice. But before that, quickly, I'm going to recap some of the points that I said in the last class. So we started talking about the definition of ptosis. By the way, this is the index from the American Academy, and as you can see, it is written blepharoptosis, because this is the most accurate, more specific professional term for ptosis, because generally ptosis means drooping of any structure. And there is a linguistically subtle difference between drooping and dropping. Drooping with double O means inferior displacement of a structure, but the structure is still in its place, okay? So the eyelid is still attached to its place, but it's drooped, it's displaced downward. But if we are talking about dropping, like drop the nucleus or drop the IOL, now there is a shift of the subject or the thing from one place to another, from inside the lens capsule into the vitreous. There is change in the place. In general, whenever we are talking about ptosis, we mean blepharoptosis, which is drooping of the upper eyelid margin beyond the normal level. And what's the normal level? Normally, the upper lid margin covers the superior 2 millimeter of the cornea. I'd like to add additional information because it will help us in the evaluation. While the patient is looking at the primary position, okay, and the eye is not hypotropic. Again, I'm stressing the importance of excluding pseudo-ptosis due to hypotropia. And if you notice, the reference point here is the globe, the cornea. So since we depend on the cornea or on the globe, we assume that everything else is okay. So the globe position is normal, there is no proptosis, there is no enophthalmos, and there is no vertical misalignment, okay, in order to document presence of ptosis. Another point that we have to keep in mind, the other eyelid. So if we are dealing with a unilateral ptosis, sometimes the other eyelid, the healthy side, is the reference point. The level of the eyelid on the healthy side is our reference, okay? Because some oculoplastic surgeons are not aiming for perfect alignment. They are aiming for symmetry. So sometimes the symmetry is more important than perfection. And in the photo, you can appreciate that the upper eyelid here covers approximately 2 millimeters of the upper cornea. You cannot see the superior limbus here. And we define the ptosis of the lower lid. It has a specific name, inverse ptosis. Normally, I forgot to mention the normal position of the lower lid margins in touch with the inferior limbus or slightly above. As in this photo again, you can see that the lower eyelid somehow, above the inferior limbus. But if we have like exaggeration, so the lower eyelid is significantly covering more than, let's say, 1 millimeter of the inferior cornea, so we can call it inverse ptosis. And this is important when we are talking about Horner. When we are suspecting a case of Horner, because in Horner, you may get ptosis of the upper eyelid and ptosis of the lower lid, all right, due to affection of the superior tarsal muscle, the mular muscle in the upper lid, and we have an equivalent muscle in the lower lid as well. Generally speaking, there are other ptosis in ophthalmology. I have added globe ptosis. So if you come across this term, globe ptosis, it means simply hypoglobus or inferior dystopia. Then we talked about the classification, how we can classify ptosis. Generally speaking, there are two systems for classification. We can classify it according to the onset into congenital or acquired. Congenital simply dating since birth or shortly after birth, acquired, of course, later on. But this is not helpful that much. So we have the other system for classification: myogenic, aperiodic, neurogenic, mechanical, and traumatic. 5 causes, all right? Myogenic means there is a problem in the muscle itself, the belly of the muscle, in the development of the muscle, maybe congenital or could be acquired as well. And if you remember, myasthenia gravis is one of the important causes of ptosis. So myasthenia gravis actually under the heading of myogenic causes. Number 2 is aponeurotic. It simply means there is something with the aponeurosis, like dehiscence, disinsertion, stretching, okay, of the aponeurosis. And here we generally are talking about the involutional ptosis, age-related ptosis, as the old name senile ptosis, okay? But aponeurotic could be caused by repeated rubbing of the eyelid, long contact lens wearer, RGP, rigid permeable contact lenses, okay? Neurogenic, generally we are talking about Horner syndrome or third nerve palsy, but we have other causes for neurogenic. And then we have mechanical and traumatic. What is the most common cause in ptosis in general is acquired aponeurotic, specifically involutional, okay? But not all the people are seeking medical advice. If of all the people are seeking medical advice, you will have like a daily list of ptosis, okay? But generally they don't seek medical advice for chismesis, okay? They don't have such active life. And then we said that congenital ptosis is mostly myogenic due to dysgenesis of the levator, but it could be other causes like neurogenic, like congenital Horner syndrome, or maybe congenital third nerve palsy. Then I mentioned a system of classification, but this is actually clinical, and we will elaborate on it in this class, in today's class, mild, moderate, severe ptosis. And the last tab here is about pupil coverage. So during the editing of the previous class, I found it like confusing. So I mean by coverage here, the visual axis blockage. Sometimes we have to decide, you have to decide whether the ptosis is severe enough to cover the visual axis or not. And this is really important when we are dealing with congenital ptosis or ptosis in children, because we are afraid of sensory deprivation amblyopia, especially if the ptosis is unilateral, covering the visual axis. There is high risk of developing of sensory deprivation amblyopia, and we need to treat such a case urgently. Also, we covered this quiz. The quiz was about what is the common theme in all photos, and you answer it as pseudoptosis. But actually, this is not 100% accurate. In order to document the presence of pseudoptosis, you have to do additional steps. So, for example, in this photo, you noticed hypotropia and we noticed ptosis or drooping of the upper eyelid. You have to confirm the presence of pseudoptosis by covering the other eye. So here, once you cover the other eye, now this eye takes up the fixation. It is in perfect alignment, and then the upper eyelid level is normal. So this is confirm the presence of pseudoptosis. So this is actually a case of hypotropia causing secondary ptosis. Because this piece of information is important, I made up this MCQ question. So let's read it together. So on observation, we've noticed ptosis on the right side with hypotropia. What would you call it? A, true ptosis with hypotropia. B, pseudoptosis due to hypotropia, both true and pseudoptosis plus hypotropia, or can't decide at that point. So the correct answer, can't decide at that point. We need to cover the other eye and see. If it is like that, so the correct answer is B. But without covering from the first photo, you cannot decide, because all A, B, C, all three possibilities could happen. And also regarding brow ptosis, this is a case of brow ptosis causing pseudoptosis, okay, due to facial nerve palsy, lower motor neuron facial nerve palsy, according to the reference. But again, you need to confirm by elevating this eyebrow and excess skin. As in this photo, this is from Kanisky. So you have to elevate the eyebrow and see the lid margin. Is it okay or not? If it is okay, then you can confirm the presence of pseudoptosis due to brow ptosis. Because simply, if you have an old patient, like a way old patient, there could be both involutional brow ptosis and involutional ptosis. The same applies also for dermatochalasis. So dermatochalasis You may think there might be like also pseudotosis, but actually it's just a lot of skin hanging over the lid margin, giving this false impression. And this photo from the American Academy, and this patient underwent only blepharoplasty, and now she looks fine. So this is actually a case of dermatocalcisis causing pseudotosis. Again, you may get a case of dermatocalcisis with true ptosis, and in such a case, this patient probably need 2 surgeries combined at one sitting, blepharoplasty and ptosis repair surgery. Third one is about artificial shell, but simply artificial shell is one of the causes of pseudotosis because of lack of support to the upper eyelid, because the position of eyelids depend also on the globe itself. So let's summarize the causes of pseudotosis. This is my preferred way for answering this question, to divide it into ipsilateral causes and on the contralateral side. Regarding the ipsilateral causes, I personally feel that the most important is hypotropia. This is nothing has to do with being an ophthalmologist, but I think hypotropia is the most important, because imagine now that there is a case of hypotropia causing pseudotosis, and then the oculoplastic surgeon did ptosis surgery for it. So now you can imagine the situation on the day 1 post-operative. Yeah, it's like a major mistake. So first, hypotropia, ipsilateral hypotropia, because this is important, I consider it as number 1, number 2, and number 3. And you have also brow ptosis. Lack of support. We have different conditions or situations for lack of support for the upper eyelid, like artificial shell, because we have like a small implant, not well-fitted shell, so you may get pseudotosis. Any kind of small globe like microphthalmia or atrophia or phthisis or anophthalmia, or even receding of the globe backward like enophthalmos, okay? And we can add also dermatocalcisis and blepharocalcisis. Please note, these are 2 entities, 2 different entities. They are not the same, dermatocalcisis and blepharocalcisis. They have something in common, which is excessive skin, but they are totally different. And if you remember, I added also in the last class overaction of the orbicularis oculi muscle, because this is simply the antagonist of levator. So if we have a patient with photophobia or blepharospasm, you will see narrowing of the vertical palpebral fissure because simply of overaction or contraction of orbicularis, not due to levator muscle weakness or anything like that. Regarding the contralateral side, like contralateral upper eyelid retraction or proptosis. This is like an overview about the causes of pseudotosis, because again, the first important question to be answered, is it true or pseudotosis? Or it could be both. Here I made some animated slides to show you the effect of the globe size and the globe position regarding the palpebral fissure. So this yellow line represents the vertical palpebral fissure. It's not accurate 100%. Just imagine there is an upper eyelid here and there is lower eyelid here. So if we have a small globe, the palpebral fissure gets narrower, okay? And the upper eyelid might descend a little bit, giving a false impression of pseudotosis. Like in this case, this is a microphthalmia, and you can see everything is small, is smaller, like the palpebral fissure is smaller. If you compare the lid margin here, the upper eyelid level here with the other side, definitely this is lowered. This is the animation for enophthalmos. So imagine this is the vertical palpebral fissure. And now if the globe is enophthalmic, again, the palpebral fissure gets narrower, as in this case. So if this is a blowout fracture, and this is Worm's view, this is enophthalmos on the left side. If you compare the vertical palpebral fissure, it is smaller here. And again, the upper lid margin is lower in comparison to the other side. And if we are going to measure the MRD1, the distance between the lid margin and the reflection, definitely it is very small in comparison to the other side. So again, enophthalmos or small globe is one of the causes of ipsilateral pseudotosis. Why it is important to rule out pseudotosis? Because such cases don't need ptosis repair surgery. They need treatment of the cause, the initial cause, all right? The last thing we talked about in the last class is the sequela of ptosis. So imagine we have a ptosis. What are the consequences or the compensatory mechanisms that you might see in a patient? On this photo, if you remember this photo, because of the ptosis on the right side, there is an attempt to elevate the upper eyelid by sending excess stimulation to the levator here and the levator here. So both levators under the effect of Hering's law of equal simultaneous innervation. So it's not in all cases, okay? There might be stimulation of levator and also another assistant muscle, which is the frontalis. So you may see on the ptotic side, high arched eyebrow. You may see corrugation of the forehead because, again, the frontalis muscle is overacting in order to improve or to fix the ptosis. So what is the consequences of this? There might be improvement of the ptosis. There might, it's not should, but there might be improvement of the more affected side if we are talking about bilateral cases. There might be masking of the ptosis on the less affected side. So imagine if the patient has a bilateral ptosis, okay? But here, on one side mild and on the other side is severe. Because of this sequela, the severe might become moderate ptosis and the mild becomes normal. So it might mask ptosis on the less affected side. It might cause contralateral lid retraction, as in this case, because the other side is healthy, the other side is normal. But because of excessive stimulation to levator, this child developed contralateral lid retraction as a compensatory mechanism because of the Hering's law. And you may get high arched brow and forehead corrugations on the affected side or the more affected side, or maybe bilateral. And I will show you cases like this later on. I categorize these sequelae under the effect of neuronal overstimulation. And there is consequences on the vision. So ptosis can affect vision, right? Regarding visual, ptosis can affect the vision by different mechanisms. If you check Wells, you will find that one of the symptoms is vision loss. By the way, vision loss doesn't mean loss of vision, like total loss of vision, like no PL. Vision loss means diminution of vision. It could be total or like complete or incomplete. So how can ptosis affect vision? You can type because typing also stimulates your thinking. It is a kind of study, and we agreed before this is like a study time. Yeah, it's not a lecture. We are learning together. It's time to practice, to study, to participate. Okay, so first of all, yeah, if we have like severe ptosis covering the visual axis in a child, this child may develop sensory deprivation and myopia. Even if we have an adult patient and we have severe ptosis, this is like an occluder barrier for vision. So if we have severe ptosis, even in adult, completely obstruct the vision. Another mechanism, yeah, you think about another mechanism. So another mechanism, they found that in congenital ptosis, there is an association between ptosis and refractive errors, in particular, astigmatism. Also, I wrote here reading. If you check your references regarding involutional ptosis, you will find that during reading or during down gaze, during reading, we need down gaze. So down gaze or reading position, the ptosis might get worse. So the patient may complain more during reading. Another mechanism, it is said that ptosis decrease the amount of illumination reaching the macula. How about visual field? Can ptosis affect visual field? And what type of visual field? Yeah, superior visual field defect. So the visual field defect is superior, like peripheral visual field superior, but again, it might affect the central visual field, like the central axis if it is total or like severe enough. What else as a sequela? Posture. So what kind of posture do you expect in a case of ptosis? If you have like a child, yeah, especially in children, chin up position. So chin up position, you expect this in kids with congenital severe ptosis bilateral because, everybody else is taller than children. So children need the superior visual field. They want to see the upper environment. So usually they adopt chin up. And this actually good because this is a kind of compensation in order to see, okay? And sometimes if we have a unilateral ptosis, yeah, it's certain in some references, if we have unilateral ptosis or because of astigmatism, there might be head tilt. And the last one is psychological. Yeah, it affects cosmesis for sure. Cosmesis per se is a justifiable reason for or a justifiable indication for surgery. So when we are talking about the indication for ptosis repair surgery, one of them is cosmesis, of course, in addition to functional indication. Okay, so this was about a summary of our previous class. Let's start the checklist. As you know, I'm going to show you some clips of the video about the evaluation. But before that, I have a disclaimer here. First, as you know, I did the steps on a volunteer. What's the meaning of volunteer? He doesn't have ptosis, so there is no abnormal findings. Initially, you can practice the steps on a volunteer, but this is not enough. You have to practice the steps on patients with ptosis and a number of patients with ptosis actually, because to be familiar with different grades, different findings, and you have to practice how to document the abnormal findings. In the exam, there is no written documentation, so you have to, again, to practice saying it loud. So whenever you do a step, you have to convey the findings to your colleague or to yourself or to the volunteer or to the patient. So you have to practice saying out loud the findings. So this is number one disclaimer. Second one, all the setting and the video recording you know is not professional. So that's why some steps are not clear. And that's why I need to elaborate on the clips and tell you what I was doing during this step. Okay, because the camera person isn't ophthalmologist. He doesn't really know what I am doing. Yeah, I was trying to explain in a layperson language. This is not enough. So that's why I will show you a clip and I will show you additional slides in order to make it clear. Again, you have to be prepared that you need to memorize some numbers. It's not that big problem, but if you practice, yeah, try to find a way or another to remember some normal numbers, because we discuss a lot of numbers today, and we will need some simple equation in order to know the degree of ptosis. Okay, so be mindly prepared. Okay, so this is like the first clip. It's all about some message. So I want here to tell you an important piece of advice. Stay calm, get ready, and be courteous and greet everyone. So because during the exam, definitely you will sit for a couple of minutes alone. Try to keep and maintain your composure. Okay, don't try to know the cases, especially if your exam on the second day, because this might be confusing. Your friend on the first day might get a case with ptosis, and then you get another case of ptosis, but totally different from the one he saw. So this might be an additional source of confusion. So try to stay calm and focus on yourself and get ready, of course, be courteous and greet everyone, including patients, okay? I like to start all my videos by general intro. It's not relevant exam-wise because, you know, you don't need to introduce yourself and take consent and so on, but this is relevant to your clinical practice. So you have to greet the patient, introduce yourself, disinfection. Here I'm using cleansing gel, so you need to get your hands dry. So while you are waiting for dryness, you can talk to the patient, explaining what you are going to do, okay, giving instructions in clinical practice, taking history, and so on. Sometimes we need the patient to see that we are caring about this infection. Introducing yourself in clinical practice, including your name, first and surname, and your position in the hospital as well. Okay, this is a checklist. We have many points, and I hope we can finish the first 2 points today. The same frame, we have special points related to ptosis evaluation. We have then general ocular, like routine ocular examination, slit lamp, biomicroscopy, and intraocular pressure measurement, and fundus examination. And we have, according to the findings, we can check some general signs or systemic findings. And if you remember, every point has an aim. We are not wasting our time doing many tests aimlessly. but we have an aim, we have a message, or we have a goal behind doing each step. So the first one is, as usual, inspection. In clinical practice, inspection starts early while you are taking his history, even open the entry of the patient to your clinic. But in the exam, you may have to spend a couple of seconds inspecting or observing the patient. So here, I'm just trying to imitate the setting based on my exam. So in my exam, in my oculoplastic exam, an oculoplastic station, actually there was only one examiner. The patient was sitting, the examiner was sitting on a chair in front of patient, and I was standing conventionally on the right side. So I was standing on the right side, unless I want to do something on the left side, I may shift. But generally speaking, this is the same as in my exam. The patient sitting, the examiner was sitting on the chair on the front of the patient, and I was standing doing the evaluation. All right. In the video, you may find me moving behind the patient. Generally speaking, this is not preferred. I did this because of the camera, because of the video recording. But if you are going to move to the left side, you have to move in front of patient. I think I kind of ethics to not go behind the patient, unless necessarily like Navziger view in Ptosis evaluation, for example. But generally speaking, if you are going to move to the left side, you have to move in front of the patient. But again, I have a stand camera in front of the volunteers. I didn't want to cross the camera axis, so I usually go behind the volunteer. Kindly write down some of the points to be evaluated or to be kept in mind. If you have noticed a ptosis, what are the additional points that to be observed in the case? And here is a clue. Ptosis starts by letter P. Again, you will find that I will show you all the points starts by P actually. First ptosis, yeah, previous scar, yeah. We say previous scars because we have different scars, because we have different types of ptosis surgery. The scar could be on the lid crease, it could be above the eyebrow. So make it general to remind yourself that we may have different kinds of scars, and it might be traumatic scar, who knows, okay? Yeah, prescription of glasses is it's always helpful, although it is not relevant too much to the ptosis. Yeah, primary position alignment, particularly hypotropia, posture, exactly. So the first point here is personal. You have to, keep in your mind the age, gender, complexion, and this personal data, or like patient's demography, because it might help you in establishing the etiology or setting the differential diagnosis and so on, or sometimes tailoring the line of surgery in general, okay? So keep in your mind the age. The most important one is age. And ptosis itself, I wrote here a number of points, but actually we will further elaborate on these points later on. So you have to keep in mind, is it unilateral or bilateral? If it is bilateral, is it symmetrical or asymmetrical? In clinical practice, is it variable or not? Because you may spend time in clinical practice, but in the exam, it's not relevant. The degree of ptosis, have an idea, although you will measure it later on. The eyebrows, here is the most important point, actually, the eyebrows. I wrote here 3 points, like 3 points are important regarding the eyebrows. Forehead corrugations, and you can see the previous scar, as one of you said. Then pupil and iris by inspection is very difficult unless you have a light colored iris, okay? But again, there is a specific point in the checklist regarding the pupil, but this is a kind of list. Just a reminder that also the tropia, although there is a specific point in the checklist regarding the ocular alignment and proptosis. I combined these 3 points together. If you remember, based on this photo, if you remember this photo, orbits, eyelids, pupils, motility, and cover tests are closely connected. Whenever you have a case in one of them, you have to comment on the other points. And as you said, posture and prescription. But I'm going to stress right now on the eyebrows. There are 3 important points regarding the eyebrows in relevance to ptosis. So we are talking in connection to ptosis. We are not talking about eyebrows evaluation in ophthalmology because we have different points. But we are talking about only 3 points in relevance or in relation to ptosis. Number one, the level of the eyebrow. And actually in this clip, you will find this clip after the inspection, the general inspection. I always assume that the left side is the abnormal. So if you noticed high arched eyebrow on the ptotic eyelid side, this means there is frontalis overaction. There is recruitment of the frontalis to elevate the ptotic eyelid. Like in this case. So this patient has ptosis on the right side, but you can appreciate the high arched eyebrow. There is frontalis overaction in order to improve, to fix up or to alleviate the ptosis. And why this is important? Because if you are going to assess the degree of ptosis or the amount of ptosis like this, you are going to underestimate the amount of ptosis. You need to negate the action of frontalis first, and I will show you how. So, because here, the amount of ptosis is underestimated. The ptosis here is a little bit better than its reality. So this is an example about high eyebrow. And remember this patient, again, from a reference, low eyebrow or drooping or ptosis of the eyebrow can cause pseudotosis. This is my comment on the level. How about the contour? Definitely, this is abnormal contour of the eyebrow, okay? And by the way, this is a kind of quiz that I will share with you probably on the last class on ptosis. But at this point, I want you to notice only that this is an abnormal contour. This is definitely not the normal contour of the eyebrow. The last point regarding eyebrows is scars. So as you can see in this child, there is 3 scars here, but actually not all are evident. There is a scar here and a scar here and also here because this child underwent frontalis suspension. So again, the 3 important points regarding the eyebrows in relevance to ptosis, the level, contour, and the scars just above the eyebrows. Okay, because you might get a case in the exam post-surgery, like post-status, post-surgical interference. Some patients underwent ptosis surgery, but they still have ptosis, like a kind of undercorrection. So they might brought a case with undercorrection. They still have some ptosis, but they have also the scars of the previous ptosis surgery. After inspection, what could be the second point? It is the same as in proptosis checklist. So the first point was observation or inspection. What could be the second point? Yeah, excellent. Measurements. So we have a lot of points to be measured, but the most important 2 are highlighted in yellow. Degree of ptosis. We assess the degree of ptosis by measuring the MRD1, margin reflex distance 1, and measurement of the levator function. Okay? But we have other points here to be assessed and to be measured, but these are the 2 most important points. Before I show you the video, I want to revise with you some terms. If you remember, if you are holding the pen torch at an arm's length and ask the patient to look at the light of the pen torch and the patient fixate on the light, you will find the corner reflection normally in the center of the pupil. This is simply Hirschberg test. So before you start measuring the degree of ptosis and before you start doing the MRD1, you can spend just a second doing Hirschberg test alone. Again, to exclude the presence of hypotropia. Okay, because if the patient has hypotropia, now your focus should be on the hypotropia, all right? But honestly, why they brought a case of hypotropia in oculoplastic station? So generally, but not always, if we have a case of ptosis in oculoplastic station, generally it should be somehow true ptosis, okay? So again, before you start measuring the MRD1, just spend 1 second to comment on the Hirschberg test. And you can say to the examiner, you can say, for example, sir, I want to do the Hirschberg test. And while you are doing it, you can say the Hirschberg is central, so there is no hypertropia, so there is no pseudotosis. Now, hold your ruler and measure the MRD1, okay? I will show you in a minute. So what is the distance between the corneal reflection and the upper lid margin? What we call this distance? What we call it? The distance between the corneal reflection and upper lid margin? Yeah, this is MRD1. And what is the distance between the corneal reflection and lower lid margin? This is MRD2. Okay. And the sum of both, if we measure the distance between the upper and lower lid margin, what we call it, yeah, vertical palpebral fissure height, okay? And always, we usually do the measure like this, in just above the reflection, and just, it's like a perpendicular line, okay? We don't do the measurement in areas other than this. So this is like the maximum width of the palpebral fissure. Let's see your answer here. What this arrow represents? If we are going to measure the distance, what does this represent? Yeah, exactly. So I was trying to trick you, but you won. Okay, so this is actually tarsal show. Okay, this is a tarsal show. I told you about this before. This is not the height of the lid crease. Yeah, here I'm just stressing the importance of the patient is looking straight ahead in the prime position and central corneal Hirschberg reflex. Okay, in order to comment on the lid crease, the eyelid crease, we need to ask the patient to slightly look down and see the line, the fold, the crease, and then do the measurements. So as you can see, sometimes you may get two lines or like duplication. So what shall you choose? Okay. Usually you will, or if you have like confronted with such a case, like two lines, which one is the crease? Yeah, you can say the most prominent one. And sometimes we retract the lid margin a little bit and see any fold. I will show you in the video. So sometimes we hold by any finger. You can try to elevate or retract the lid margin a little bit and see which one, where is the fold. It must be one of them. Or simply you can say the most prominent one. This represents the lid crease, and then you have to measure the distance of lid crease. This is one of the points to be documented as well. So I brought this photo just for fun because I don't know, but I think the model here is somehow looking downward, and I want you to appreciate the, here, this is the lid crease here. Okay, this is the lid crease. So this is actually the distance of lid crease from the lid margin. All right, but this area is the tarsal show. I said before that tarsal show, sometimes we call tarsal show eyeshadow area. Okay, so there is a difference between the distances, okay? Again, in order to comment on the lid crease, you need to ask the patient to look down. But imagine you have a patient with like severe ptosis, okay? And let's say bilateral. There is no point of asking the patient to look down because the eyelids are already in down position. They are already drooped. So this is why I told you before that there might be some differences between doing the steps on a volunteer and on a normal subject and doing it on a patient. Sometimes when you are doing a step on a patient, we need to do some little modification, okay? So in my video, because I'm dealing with a volunteer, I asked him to look down in order to measure the lid crease distance. But if we have like severe ptosis, we don't usually ask the patient to look down, okay? Again, this is from academic point of teaching, you need to comment on the lid crease. But actually, when you are going to document the position of lid crease, we usually do it on table, on the operative table before doing the surgery itself. But from exam point of view, you have to comment on the lid crease position because also it's a useful point in order to comment on the etiology. Sometimes it's helpful in identifying the etiology. I will tell you in a moment. Again, the first step, which is the first step, is Hirschberg test. Okay, spend 1 second doing only the Hirschberg. So as you can see here, I'm just holding the pen torch. I don't have any rule in my hand. I don't have any ruler to measure the MRD1. I just started by doing the Hirschberg test. Because of the angle of photographing, the camera person is using, I don't know, an option. You might think that I am staying very far from the patient, but actually I'm not staying that far. I'm just an arm length from the patient. But this is an apparent distance. It's not the true distance, okay? So I'm holding the pen torch as an arm length in order to observe the Hirschberg test and the reflection in the center of the pupil of each pupil. All right. And of course, he has central Hirschberg test. Okay, there is no hypertropia. Then I started measuring the MRD1. So now I'm starting on the right side. I'm holding the pen torch by one hand and then and the ruler by the other hand, and measure the distance between the cornea reflection and the upper lid margin on the right side, and then on the left side. You have to do it bilateral, okay? Even if the ptosis is unilateral, you have to do it bilateral. Because even if it is unilateral, the other healthy side is your reference, okay? And I repeat it again on the right side, and it's okay to repeat. If you are not sure about anything, you can repeat it quickly, okay? So this is how we measure the MRD1. Here you can see that there is an A and then question marks. So this is the first way to measure the margin reflex distance. Okay, this is the first way to measure the margin reflex distance. But actually, there is another way, and it's more accurate. Okay, there is another way to measuring the MRD1, and it's more accurate, especially if you've noticed that the patient has high arched eyebrow and there is frontalis overaction and there is recruitment of the eyebrow. So as you will find you find me here explaining that if the patient, especially if the patient has overaction of the frontalis and high arched eyebrow, this means that you need to negate the action of the frontalis at first. Okay. So if the patient has, you noticed frontalis overaction, high arched eyebrow, you need to negate the action of frontalis. You have to abolish its action, because if you are going to measure the MRD1 without negation of the frontalis action, the amount is underestimated, okay? So how we can negate the action of frontalis? First, you ask the patient to look down, as you can see here in this video. So I'm just holding a target or holding the pen torch, just a target, but sometimes you don't need to hold any target. Just ask the patient. If the patient is cooperative enough, you can ask him or her to look down. So this is the first step. All right. So first step, to ask the patient to look down. Why? Because in down gaze, everything is relaxed. All elevators are relaxed. The elevator is relaxed. The frontalis is relaxed, okay? So everything is relaxed. So here is the first step, ask the patient to look down. The second step, so again, whenever you ask the patient to look down, there is a kind of reflex that the patient has a tendency to flex their necks, okay? So try to keep the neck straight ahead and perfectly aligned, okay? I don't know if you have noticed this or not, but here I'm trying to align the head itself, okay? So now the volunteer, he is looking down and the head is straightened, okay? And then you place your thumb on the eyebrow. So this is how we can negate the action of frontalis muscle, because if we press on the insertion of frontalis, and you know the frontalis is inserted at that place, this prevents the frontalis from doing its action, okay? And then you ask the patient to look at the pen torch, okay? Here I need a third hand, and that's why this method is a little bit cumbersome and a little bit difficult, because you need a third hand. Here I ask the volunteer to hold the pen torch because I'm going to hold the ruler by my other hand, okay? And then lastly, you measure the MRD1. But here you are measuring the MRD1 without the help of the frontalis. So you are sure now you are not underestimating the action of the amount of ptosis. And I did it on the same side. Again, patient look down, press your thumb on the eyebrow, ask the patient to hold the pen torch, and then measure the distance between the reflection and the upper lid margin. So you have two methods. The first one is very easy, and you can do it, but if the patient has high arched brow or you want to do the test more professionally, you can do the other technique. Let's say some numbers. I'm trying to simplify the numbers because it's really important to know how to do the normal. And of course, there is a range, and we have variability among people, depending on the age, gender, race, and so on. So this is how I learned the number since I was like a medical student, okay? So let's say it together. How I can memorize these numbers. Of course, I think you know that what is the vertical diameter of the cornea? Generally speaking, yeah, we can say it's what? It's 12, okay? It's 12. And whenever you say a number, you have to say the notation. So it's 12 millimeter, all right? So, of course, the cornea reflection divided into 6 up, and you have 6 millimeter above and 6 millimeter below, okay? So let's see here. So since the upper eyelid covers 2 millimeter in this of the upper cornea, this white arrow, so the remaining, the red arrow here is 4 millimeter. So this is the normal MRD1 because MRD1 is the distance between the lid margin and the cornea reflection. So the MRD1 is 4 millimeters. 4 millimeters, okay? How about the MRD2, the distance between the reflection and lid margin? It's a 6, okay? Remember, it's a 6. So this is a normal MRD2, 6 millimeters. And what's the normal vertical papillary fissure? Again, it should be in a range, but this is to simplify, is the sum of both. It's 10 millimeters. This is how I memorize these numbers. So generally speaking, MRD1 is 4 millimeters. This is for simplification. But sometimes, again, if we have a unilateral ptosis, we may consider the MRD1 on the healthy eyelid as a reference point. So suppose the other healthy side, the MRD1 is 4.5 millimeters. So this should be your reference, okay? But otherwise, if we are dealing with bilateral cases, or if we are luckily confronted with a case where the other healthy side MRD1 is 4 millimeter, thanks God, because the calculation later on would be easy. All right. So let's see the next slide. The next slide was taken from Kanisky, and I really liked this image because, again, it is simplifying everything. If we enlarge this area, you will find that the vertical papillary fissure is 10 millimeters. The ruler here starts with 0 here. It is 0, okay? So 10 millimeters. And if you count the MRD1, like 1, 2, 3, 4, you will find the MRD1 is 4 millimeters, and you will find the MRD2 is 6 millimeters, okay? So this is what we just said. How about the lid crease? Generally speaking, you can easily remember this number, 6, 8, 10. So 6 millimeter in children, 8 millimeter in men. Women usually has a higher crease and wider palpebral fissure. So yeah, everything is a little bit bigger in women when it comes to the palpebral fissure dimensions. So here the crease is 8 millimeter in men and women is 10 millimeters. All right. How about the tarsal show? I don't think it's really important to memorize the number of the tarsal show because it's widely varied. So you may find in some references like 2 to 3 millimeters in middle-aged person. This is a photo of a child. You can appreciate a wide tarsal show. And this is my photo. I brought it because sometimes as a normal variation, you may find asymmetry in the tarsal show, but there is no ptosis. So you may think this is a ptotic side because the tarsal show is widened here, because whenever we have a ptosis, you might expect wider tarsal show, but actually I don't have any ptosis. So I don't have any ptosis, but I have just subtle asymmetry in the tarsal show and also in the configuration of the eyebrow. So sometimes there is normal variation. If you are interested to know a lot of numbers, you can also memorize the number of the tarsal show. How about the horizontal palpebral fissure width? This is not really important unless you are dealing with a case with blepharophimosis. So you have to know the normal. For simplification, I would say 30 millimeters, like 3 centimeters. But generally speaking, we use millimeters in measurements, so you can say 30 millimeters. So please don't confuse, because some might be confused but between MRD1 and degree of ptosis. MRD1 is a step. We do it to measure the degree of ptosis. They are not equivalent, okay? So MRD1 is not equal to the degree of ptosis. Actually, the relation is like opposite. If we have MRD smaller, it means that the degree of ptosis is bigger, okay? So how we can calculate the degree of ptosis? I don't know, I wrote it in the form of equation. So how we can assess the degree of ptosis? So we need to know the normal value of MRD1 minus the MRD1 in the patient, in the case. So the result would be the degree of ptosis. For simplification, we usually assume that the normal value is 4 millimeter. Unless the other side is healthy and the MRD1 is like not 4 millimeter, like let's say 4.5 millimeters, then you have to use 4.5 in the equation instead of 4, okay? So in order to determine the degree of ptosis, I will show you in the following slides, by the way, because I have some animated slides for this. So the normal value of MRD1 minus the value in the patient, the result would be the degree of ptosis. For simplification, we use 4 milli as a normal value in order to make it simple. We have here examples using animation. So imagine this is a normal. So this is MRD1, 4 millimeters. Okay, what is the MRD1? The distance between the reflection and the upper lid margin. Now we have drooping of the upper eyelid. And then you measure the MRD1, you found it 2 millimeters. So what is the normal MRD1? 4 minus 2, which is the MRD1 in this patient. The result is 2 millimeter. So this is the degree of ptosis. So the degree of ptosis in such case is 2 millimeter. And you know, 2 millimeter, it means mild ptosis, okay? Another example, if we have more drooping, and then you measure the MRD1 and you found it 1 millimeter. So what is the degree of ptosis? 4 minus 1 equals 3. So the degree of ptosis is 3 millimeters. And actually, this is called moderate ptosis. Another example, if we have much drooping of the upper eyelid, and you know the lid margin is in touch with the corneal reflection, or like crossing the corneal reflection. So actually, in such case, the MRD1 is 0. So what is the degree of ptosis? Is 4 millimeters. So this is actually severe. So once you notice, if you remember the points to be assessed in inspection, once you notice the ptotic eyelid is covering the center of the pupil, the reflection, definitely this is severe without any measurements, okay? So do you have another example? Yes, we have another example. Sometimes we have severe ptosis, like covering beyond the corneal reflection, like this case. Here, actually, the MRD1 is calculated in minus. So here, if the upper eyelid drooped beyond the corneal, so like below the corneal reflection, the MRD1 would be in minus value. Again, this is severe ptosis. So how we can measure exactly the MRD1 using minus value in such a case? So imagine this is a patient like with almost total ptosis. But from academic point of teaching, like how we can measure the MRD1. Simply, you retract the upper eyelid by your finger, okay? Bring the pen torch, ask the patient to look at the pen torch light, okay? Then place the ruler 0 opposite to the corner reflection. Then remove your finger. Keep your ruler still in the same place, okay? Remove your finger. Allow the eyelid to droop and measure how many millimeters opposite on the ruler. Like here, it is, yeah, maybe like 2 millimeters. So, but it's not enough to say 2 millimeters. You have to say minus 2 millimeters. So any doctor like revising the chart or the file of the patient, and this person found -2, the first image that will come to his mind that this is beyond the cornea reflection. So minus here means that upper eyelid is lowered below the cornea reflection. So the MRD1 is -2. So what is the degree of ptosis? We have 4 millimeter above and we have 2 millimeter below. So we have the degree of ptosis here is considered as 6 millimeters. Okay, again, this is severe ptosis for sure. So this is how we measure the MRD1 in such case, in such severe cases of ptosis. All right, so here, this is how we grade ptosis. So first, again, to revise, to make a quick summary, we measure the MRD1, and from that number, we assess the degree of ptosis. And we have a system like mild, moderate, severe, okay, according to the amount of ptosis. If it is less than 3 millimeters, so this is called mild. If it is 3 millimeter, this is called moderate. If it is more than 3 millimeters, it's called severe, okay? Here I wrote if the upper lid just in touch with the cornea reflection or like worse, definitely it is severe without any measurement. And again, this is from Kanisky, the same as we said. Once the cornea reflection is not visible, this is severe for sure without any measurement. Okay, so we finished this point, the degree of ptosis, assessing the degree of ptosis by measuring the MRD1. Here I added 2 points because somehow it's related to the degree of ptosis. Herring's law. So what I mean by Herring's law? Let's watch the clip at first. Imagine that we have ptosis on the left side, and by inspection, you noticed only ptosis on the left side. You have to do Herring's law because how we can do it, Herring's law? You manually elevate the ptotic eyelid and at the same time, look for the eyelid on the other side. So again, you elevate the ptotic eyelid and see what happens on the other eyelid. So for example, on inspection, this is a ptosis, but here we have a contralateral eyelid retraction. And this is taken from one of the, this is a wonderful lecture, yeah, I advise you to watch it from Cyberside Library, yeah. Okay, so how we can do the Herring's law? So manually elevate the ptotic eyelid. Now the lid retraction corrected, okay? And this is a normal position of the eyelid. Okay, so this is positive results. Herring's law applies on this case. Okay, so before there is no fear of this lid retraction. This is a kind of compensatory lid retraction. But let's see this example. This is from the American Academy. We have ptosis here. Here the examiner elevating the eyelid. So see what's happening is the eyelid on the other side becomes more droopy, okay? So if you notice the MRD1 here it is better than this. So actually this patient has a kind of mild ptosis here, but by manually elevating this ptotic, the more affected side, the ptosis becomes here like moderate to severe. Okay, and that's why we said before, because of the neuronal or the Herring's law, it might mask ptosis on the other side or might make it less evident. Okay, so this is an essential step, especially before doing surgery, to document the Herring's law in every case. When we elevate this eyelid the other eyelid descend. This is a sign, actually. It has a name. Do you know the name? Because this is important when we are talking about, or when you study myasthenia gravis, it might be encountered in cases of myasthenia gravis, because myasthenia gravis is always usually bilateral asymmetric, okay, ptosis. So again, if you elevate the eyelid on one side and you get a positive result and drooping on the other eyelid, actually it has a name and it's called enhancement of ptosis. Because by this maneuver, you enhance the ptosis on the other side. It becomes more evident. And sometimes it's called curtain sign or seesaw ptosis. You know seesaw, the game? This is called seesaw sign. So this is like positive seesaw sign on such a case. Because in such a case, you may counsel the patient before the surgery that usually it's important while you are counseling, you have to warn the patient that when you are going to correct the ptosis on the affected side, there might be a ptosis post-operatively on the other side. And usually patients choose to operate on the affected side first and see the result and then decide. But this is something important in clinical practice, actually. Let's read it together. Unmasking of right upper eyelid ptosis with elevation of the ptotic left upper eyelid, demonstrating the effect of Haring's law of equal innervation. Okay. When you manually elevate the more ptotic eyelid, what could be the results? There might be not significant change on the other side. This is one possibility, or there might be change. So what could be the change on the other side? The other side might have contralateral retraction, then becomes normal, or the masked ptosis becomes evident, or ptosis on the other side becomes more significant. Okay, so these are the possibilities whenever you do manual elevation of the ptotic eyelid. No change or change. So this is a summary of the possibilities in any case. The next one, what I mean by up versus down. In this clip, I'm actually not testing the like motility. This is not a test for motility because there is a specific point in the checklist regarding motility testing. But here I'm looking for something called lid lag on down gaze. So here the both eyelids move smoothly from up gaze to down gaze. Because sometimes we confronted with cases with lid lag on down gaze in ptosis. And I have shown you before this video from Showa website. In some cases of congenital ptosis with dysgenesis of levator, not dystrophy, but dysgenesis, as this patient, here we have ptosis, okay? Now in up gaze, and now notice while moving down, here the upper lid is lagging behind the globe. And actually, you know, it's a kind of lid retraction on down gaze. And even if you measure the vertical pupil fissure, it's like wider than the other side. So let's watch it together again. This is called the lid lag on down gaze in some cases of congenital ptosis. And I mentioned before why, what's the reason behind this? Because in congenital ptosis, we have fibrofatty deposition of the levator, dysgenesis of the levator. So on down gaze, we need relaxation of the levator. But actually, because of this pathology, levator can't relaxate normally. So due to defect in relaxation, there is lid lag. Because on down gaze, we need the relaxation of the levator, okay? So there is no muscle responsible for moving the eyelid downward, done by relaxation of the levator and other levators, like frontalis. So this sign is called lid lag and down gaze. Again, this is a snapshot from the video. And as you can see, if you compare the vertical pupillary fissure in up gaze and down gaze, so this is a vertical pupillary fissure on the healthy side, and this is a fissure on the affected side. Again, this is a clue that there is ptosis here, okay? Because whenever we have ptosis, the vertical pupil fissure is smaller, okay? But compare now on down gaze. So actually, the ptosis improved on down gaze. We can say it like this: the ptosis improved on down gaze because of the lid lag. So on down gaze, if you say lid lag on down gaze, this is a sign, this is correct. And you can in your mind, but don't say it to the examiner. There's a kind of retraction of the eyelid on down gaze. Again, it's correct. And you can say it is a kind of improvement of ptosis on down gaze. Because you know the fissure is now is actually better than the fissure, the vertical pupil fissure on the healthy side. And this is from the American Academy. Again, this is ptosis on the left side. If you compare the up gaze by the down gaze, again, this is a lid lag. If we highlight the level of the eyelid here, it's here. But here on the health side is lower. Okay? So this is called lid lag on down gaze. You will find it in the description here, lid lag. Down gaze reveals lid lag. This sign is important clinically because this patient may have also lag of thalamus and may be at risk of exposure post surgery. And also it helps us in identifying the etiology. So whenever you have a case of ptosis with lid lag, we usually think of congenital ptosis. So let's summarize in general. I think I said this slide before, but let's repeat it again. What are the causes of lid lag in down gaze in ophthalmology? We mentioned before in thyroid patients. So in thyroid eye disease signs, one of the thyroid eye disease signs, lid lag on down gaze. So what's the name of this sign? In thyroid patient, if we have lid lag on down gaze in a thyroid patient, what we call this sign? This is a kind of revision. Yeah. One grade. And now we have a second cause, congenital ptosis. Another cause, if you remember, I told you before, if you have like scarring in the area of the superior orbit and eyelid and so on, because in order for the eyelid to move, there must be no scarring, no any tethering forces, okay? So, but this is not really important actually. We can omit it or make it in gray like this one. But there is an important cause, and this important regarding or in relevance to ptosis actually. I'm going to give you a clue. So in apparent third nerve regeneration, actually it's not lid lag. Actually, the lid elevates. There is stimulation of the levator. We don't call it lid lag on down gaze. In apparent third nerve regeneration, the eyelid elevates. If you remember from your study book, the eyelid elevates on down gaze. It's not lid lag. Okay, so it's post ptosis surgery. And I'm a very demanding person when it comes to teaching, so you can add more details. Which one? We have different kind of surgery. Which one do you expect significant lid lag on down gaze? Which one of the surgeries? What do you think? Yeah, any kind of frontalis suspension surgery, and yeah, frontalis suspension. Okay, and we can also add one powerful surgery, which is maximum levator resection. Okay, this is a subtype of levator resection. We have like a surgery called the maximum levator resection. So you might expect also lid lag on down gaze. Okay, the next point is about levator function. Let's watch the clip first. So again, you ask the patient or the volunteer to look down. Target is not necessary. You can just instruct the patient to look down, okay? But I was holding a target as a pen torch, but it's not necessary. Just instruct the patient to look down. All right. Then you place your thumb on the eyebrow. Focus on the medial 2/3 because this is the most critical point. Again, it's just you are pressing backward against the bone without depressing the eyebrow or elevating the eyebrow. Because if you are depressing downward the eyebrow or elevating the eyebrow, this might cause errors in your measurements. Okay, so you are just press against the bone, okay, without displacing the position of the eyebrow. When you are assessing the levator function, you ask the patient to look at the extreme up, okay? So from extreme down to extreme up. Again, the first step, patients look at the extreme down. Then place your thumb on the eyebrow. Just press against the bone. Then place your ruler, keep the 0 at the lid margin. And then ask the patient lastly to look at far up, like look up and see how much it measures on the ruler. And do the same on the other side. Keep the head still and straight. This is much close up, so you can observe now the 0 should be at the lid margin in the middle, and then the patient asked to look up. It might seem to you that the patient is looking like straight ahead because the camera person is actually photographing from above, but actually I asked him to look up, okay? And see the lid margin, the number opposite to the lid margin here, okay? Normally it's like 15 to 20 millimeters. I want one of you to unmute and tell me the steps again. I want to write it down on this slide.
So, good morning, ma'am.
Good morning. How are you?
Yeah, fine, ma'am. So, I'll first ask the patient to look down.
So this is
Then,
this is instruction. So instruction here to look down.
yes.
Okay.
Then I'll place the scale with the 0 at the lid margin. Then I'll place the eyebrow. I'll place my thumb over the eyebrow. Especially the medial 2/3 should be medial 2/3 of the brow should be held firmly. And then I'll ask the patient to look as far as up as possible, the maximum up case, and I'll measure the exertion of the lid margin.
Okay, thank you. I like the excursion of the upper lid because actually we are not assessing the levator function. It's not possible, but we are actually measuring the upper eyelid excursion, which reflects the levator function. Thank you.
Thank you, ma'am.
And you have to do on the other side.
On the other side, okay.
It's really important to keep your ruler still, okay? So don't change. So once you place the ruler or the rule at the lid margin, okay, while the patient is looking down, keeping the 0 at the lid margin, keep your hand still, okay? Keep your hand still. Because any change in the position of the rule can give enormous measurements, okay? Okay, so this is the steps for measuring the levator function, okay? And this is from Kansky, and you have to know these numbers actually. Always remember that if the levator function is 4 millimeters or less, this is poor, okay? And normally it is 15 to 20 millimeters, this is a normal. And we have good function and we have fair function. The most important to remember is, I think, the one in green and the one in red. Okay, find a way to memorize these numbers. Okay, is it necessarily to use a transparent ruler? Actually, it is a matter of preference. It's not necessarily to be transparent, okay? But you have to make a little change if you are going to use like opaque one. So whether we are talking about the marginal flex distance or here in the levator, So if we are talking about the margin reflex distance, in case of transparent, you can place it directly in front of the corner reflection because it's transparent and the patient can observe. But here you have to notice something important. Here it is about measuring the levator function. You can see here the somehow it's really important to keep. So this is the lid margin here. So actually the lid margin is not exactly opposite. There is some movement here. So here is the lid margin here. There is somehow shift in the position of the ruler, and this might cause an error that, as I said before. Okay, so this is not 100% accurate because the examiner here somehow shifted the position of the ruler. That's why it's really important. Once you place the ruler at one position, okay, keep your hand still. Okay, but imagine right now that it's correct. Okay, it's like it's about like this mark. And now, how about the excursion? The excursion here is here. So you have to look at this point, not this point. Okay, this point is in the middle of the palpebral fissure, like the maximum width of the palpebral fissure. So, and you see and see how much the distance between both. Okay, so although the ruler here is placed to one side, like here in this area, but you need to measure the excursion. Like imagine that line is like extending, and see what the number here and this number and the number here, and see the amount on millimeters. This is the levator excursion. Okay, so even if you place your ruler to one side, like laterally, as in this photo, you have to, the reference should be in the middle of the lid margin here and the middle of the lid margin here, because this is the maximum width of the palpebral fissure. Okay, so you have to keep this in mind. There is one mistake here, because here, when the examiner asks the patient to look down, he placed the ruler, but again, there is a shift in the position of the ruler. So this is not correct. You have to keep your hand still. We have other points like what? Like the eyelid crease. Let's watch the clip. So here, I asked the volunteer to look down. Again, I'm using the pen torch, but the target is not necessarily, okay? So you see this movement by my hand, because actually he has like more than one lines. So I was trying to search which one is the lid crease. So I'm by my finger, you will see in a moment here, I'm trying to retract the lid margin to see which one is the correct one. And then measure the distance again from the widest point here, the farthest point to the lid margin, and just represent the lid crease. And do the same on the other side. Always do the measurements on both sides. Okay? Somehow it's like 8 millimeters. By the way, I'm using here a ruler, but sometimes it's better to use the ruler which has like scales on both sides. Like some rulers have scales on each side. And if you are familiar or you are happy with the non-transparent one, you can use it. Again, here I'm just using the cotton tip applicator to highlight the presence of the lid crease. And you know, the lid crease represents the attachment of the levator aponeurosis to the skin. So let's fill this slide together. What is the significance of lid crease? Or assessing the lid crease, or looking for the lid crease? Okay, it could be like absent. Okay, We have causes for absent lid crease, or it could be what? High, yes, high in aponeurotic ptosis, and yeah, so surgical anatomy, like landmark for the incision before incision. If we're going to do levator advancement, levator resection, any kind of such kind of surgeries transcutaneous, we place the incision over the lid crease. Okay, excellent. So I got an answer. So absent lid crease, actually, absent lid crease. This might be confusing. So absent lid crease, what does mean absent lid crease? It might mean poor levator muscle, and you might expect this in congenital ptosis, some cases of congenital ptosis, of course, or in severe apneurotic ptosis. Because in apneurotic ptosis, there is dehiscence, stretching of the aponeurosis, and sometimes disinsertion, like complete disinsertion of the aponeurosis from its attachment to the skin. So in such case, you will get absent lid crease. So actually, there is two causes for absent lid crease: poor levator function in some cases of congenital ptosis, and in severe apneurotic ptosis. Still one missing here. What is the significance of commenting on the lid crease? There might be scar or maybe stitch of previous surgery. Okay. So again, we have two causes for absent lid crease. So this is a case of blepharophimosis, but this is an example of congenital ptosis with poor levator function, because generally speaking, in blepharophimosis, we usually the levator function is very poor, and you can see that there is no lid crease on both sides. So this is an example of congenital ptosis, severe ptosis with poor levator function and absent crease. And here in this photo, this is a case of from Kanisky from aponeurotic ptosis, involutional ptosis, severe cases, and there is no crease. Actually, this is actually the sulcus. We call it deep superior sulcus. This is not the crease. There is no crease in such a case. Okay. Sometimes there is also thinning of the skin of the eyelid, and you can appreciate the cornea behind the eyelid. All these signs are indicative of involutional ptosis. So it's really important to comment on the lid crease while you are evaluating. So this is a case of congenital ptosis, but there is crease. So there is crease. So not all cases of congenital ptosis you will see no crease. No, there is crease here. This is a case of poor levator function. There is no crease. Here, this is one of our institution cases. You will find stitches here. Here is the scar of the previous levator resection surgery. Okay. This is a case of aponeurosis. There might be a crease, a shallow crease. So you have to comment on the crease, present or absent. Is it shallow? Is it high? And you have to measure it. All right. So what are the signs of poor levator function and the significance? Yeah, we just said absent crease. Number two, if the excursion is 4 millimeters or less. I mean here by excursion, the upper eyelid excursion. And there is another point I will mention later on in the next class. So what's the significance if we have a poor levator function?
We can't do LPS resection surgery, plan for surgery.
Okay, you can or you cannot?
We cannot.
We cannot. So be careful, because if you said you can't, sometimes the examiner may hear it like can. So speak slowly and make it don't say contraction in order to be clear. So instead of mentioning the negative, why you didn't say you have to do frontalis suspension instead? Okay, so its significance, you do frontalis suspension, or as you said, yeah, levator resection is not the surgery of a choice. So levator resection, and again, you mentioned abbreviation, and please don't say abbreviation in the exam. So levator resection isn't the surgery of choice. But again, there is a surgery called maximal levator section, maximum levator section. Some surgeons do it for severe, like in patients with poor levator function. But let's make it simple. So if you have a poor levator function, we need the frontalis to suspend the eyelids. So we usually do frontalis suspension, one of the frontalis suspension surgeries. Another significance, again, it might help you in the etiology. Here I'm just showing you how we can mark the lid crease. This is important before doing any levator resection. So really important to mark the lid crease. And this patient, post-status after maximal levator resection surgery, actually this is a scar. So what you are seeing now is exaggeration of the crease because actually there is a scar. So be careful because sometimes the scar is very subtle. So you have to keep this in your mind. This has been taken from the American Academy, and it shows you how we can document the findings. So for example, you can see here ptosis on the right side, right? So you will find that in American Academy, the MRD1 is, so you see the sign is important. So they wrote plus 0.5, so the distance, so even if you are an oculoplastic surgeon or you are interested in research or things like that, you have to even document subtle measurements like 0.5 or even 0.25, okay? So here the margin reflex distance is 0.5, okay? And MRD1 on the other side, like plus 3.5. It's almost normal because normal is like 4 to 4.5. And then the MRD2 is the same on both sides, okay? And as you can see, it's less than 6 millimeters because you can see that the lower lid is a little bit covering a part of the inferior cornea. And the vertical pupil fissure is just as the sum. If you like 0.5 plus 5.5 equals 6. And here, if you make adding, you will find 9. So as you can see, the vertical pupil fissure is smaller on the ptotic side. Again, there is a comment on the lid crease. And now you can see it's high crease because this is a case of involutional ptosis. And one of the signs of involutional ptosis, high lid crease. But in severe cases, you may have no crease at all. So here it's 12, but on the other side, it's normal because we said before that the lid crease in men usually 8 millimeters. And the levator function, yeah, this is one of the signs of involutional ptosis. Despite the presence of ptosis, the levator function is normal, okay? So this is like 15 on both sides. They are symmetrical. So levator function is 15 in each side. And there's another point, we will mention it in the next class about lag of sulmus. There is no lag of sulmus, okay? So you have to practice this. So if I ask you, what is the degree of ptosis on the right side? Can you tell me? Because the degree of ptosis is not mentioned here. What is the degree of ptosis on the right side?
It's moderate to severe ptosis.
Okay, excellent. So in such a case, I will use the other side as a reference. So I would imagine that the margin reflex distance, the normal margin reflex distance is 3.5. So this could be my normal value, and subtract 0.5 from it. So we have 3 millimeters of ptosis. If we have 3 millimeters of ptosis, you consider it as moderate ptosis. Okay, we consider it as moderate ptosis.
However, if you consider the normal margin reflex distance 4 millimeters, we can say in such a scenario that we have mild ptosis on the left side. The degree of ptosis is 0.5 millimeters, and we have severe ptosis on the right side with the degree of ptosis 3.5 millimeters.
Okay, and what else? You will find in the video that there is a separate clip for measuring the vertical palpebral fissure and the MRD2, although I can do it all. So in one go, you can do all the measurements. You can measure the MRD1 and MRD2 and vertical palpebral fissure at one time. But I use a separate clip for measuring the vertical palpebral fissure. Actually, this clip for measuring the vertical palpebral fissure and the MRD2. Because I'm not good at multitasking, so I need to focus on one step at a time, okay? And I will justify my way in a moment. I have to mention this note because it's written in Kanski and you probably have read it before. Generally speaking, in practice, we usually, when we are going to measure the vertical palpebral fissure, we can measure it while we are measuring the MRD1, or after measuring the MRD1. You ask the patient to look at the pen torch, but actually we don't need a pen torch for measuring the vertical palpebral fissure. You just measure the distance between the upper and lower lid margin, and that's it, okay? But in Kanski, it's written that the patient should fixate on a distant object, but pen torch is not a distant object. Okay, this is what is written in Kanski. We measure the vertical palpebral fissure at the widest point, and the patient is fixated on a distant object. But I don't think it really matters, okay? So I'm going to end this presentation by a question of the day, and one of our learners asked this question. So greetings, while examining ptosis, okay, can we measure MRD1, vertical palpebral fissure height, and upper lid crease between brackets pre-tarsal show in one go? Let's answer this together because this is a good question. First, lid crease is not equivalent to pre-tarsal show. Lid crease is one thing and pre-tarsal show another thing, okay? And we said this before at the beginning of the class. Second thing, let's make it another color. In order to assess the lid crease, generally speaking, we ask the patient to look down. So patient should look down. I said before, we have an exception. What is the exception? If it's already we have like bilateral severe ptosis, both eyelids are already down, okay, are already drooped. There is no point of asking the patient to look down. Now coming to MRD1 and vertical palpebral fissure, okay, this point. And also, we can also add MRD2. Yes, you can measure the MRD1 and MRD2, and the sum of both is vertical palpebral fissure in one go, as in this slide. So this is actually from a reference, and as you can see from the comment, the examiner actually measuring so you will find the distance between the reflection and the lid margin. This is MRD1, and the reflection here between the lid margin, lower lid margin, and the reflection is MRD2, and the sum is the vertical palpebral fissure. Okay, you can do it. It's no harm of doing this, but actually in practice, and I think from exam point of view, is vertical palpebral fissure height and MRD2 are actually an additional and not that important points to be assessed. You have to focus on MRD1, make the calculation in your mind, mention the degree of ptosis, then measure the upper eyelid excursion, and usually the examiner will stop you at this point and ask you the follow-up questions, okay? Because there is no time in the exam to do all the points. The checklist has a lot of points, but this doesn't mean that you have to practice these points, by the way, but this doesn't mean that you will do these steps in the exam because there is no time. You will need like 15 minutes to do all the steps. So usually the scenario in the exam is like, as I said, focus on the MRD1, do your calculation to elicit the degree of ptosis, mention the degree of ptosis, okay, comment on both sides, mention the levator function, and generally the examiner will stop you at this point, okay? But of course, you need to know how to measure the MRD2, and you need to know how to measure the lid crease, and you need to know how to measure the vertical pupil vision. But if you are good at multitasking, good for you. You can do it. So this is actually my philosophy. I need to focus on one point, the most important one first, and then we can think about the additional details. Okay? All right. I think this is the end of our presentation. The remaining points, there is other points here. I think it's not necessary, but I'd like to comment on the tarsal show. And if we have like scleral show, because sometimes the lower lid margin is actually in some patients or in some people is not, sometimes there is a rim of sclera between the lower limbus and lid margin, and you have to document this amount of limbal show or sclera show. Okay, again, from research point of view, you may be interested to know the level of the eyebrow. Last video clip here, I'm showing you how I measure the horizontal palpebral fissure width. Again, there is no need to hold a torch because you are measuring the distance between the inner canthus and lateral canthus. It doesn't really matter if the patient is looking up or down because the position of the inner canthus and outer canthus doesn't change by the gaze. As you can see, it's about 30 millimeters, okay? Again, this is an additional extra step, but it's important when we are talking about blepharophimosis syndrome. And as you can see, there is a hidden bar here. So those who are asking about myasthenia, Bell's phenomena, and so on, it will be in the next class. Thank you so much, and see you next year. Any questions? Okay, I shall end the, yeah, thank you, you're welcome. So I shall end the presentation right now. We still have 2 classes in Ptosis. The next class will be about the remaining points in the checklist, and the last class, which I would imagine it would be the most lengthy one, to cover some of the past candidate experiences, quizzes, and closing slides. See you soon, have a good day, bye-bye.